Hi, I'm Dr. Rajiv. So we'll start with the CVS disorders. Okay, so in this particular session, we are going to discuss about the basic diseases, like how to approach a disorder. Okay, approach. So we are going to discuss about the approach. So what is the approach? Approach basically means like for any serious disorder, what we are going to do first is always revise physiology. Okay, so review of physiology. Okay, after that we'll go through the symptomology, then the assessment methods. We'll go for the indexing or the classification of the particular system, and then we'll go for individual disorders where we can define the particular disease by any keyword. Then we can go for epidemiology, then etiopathogenesis, then clinical features. Okay, so then the diagnosis, and then the treatment and the prognosis of particular disease. Okay, so this is the basic approach we are going to discuss in a later part of this video. So in the first a serious disorder, cardiovascular disorder, we are going to see how it is classified. Okay, so first is the functional classification, second the structural, third is the vascular part. Okay, is the vascular part. So in the functional there is arrhythmia. So while we are going to discuss about arrhythmia, we should know about ECG. Okay, ECG in detail. Okay, so we'll have a separate video on ECG, and we'll discuss about how the rate and rhythm, there is an dysregulation and which causes the arrhythmia. Okay, in the structural part we'll discuss about the congenital heart disease, we'll discuss the valvular heart disease, the cardiomyopathy, and pericardial disorders. Pericardial disorders. In the vascular part, we are going to discuss about the hypertension and the coronary artery disease, that is the ischemic heart disease. We'll discuss about angina, we'll discuss about MI, and we'll discuss about more of the or remaining topics. Okay, and also in the serious disorders there is a part of cardiac tumors. Cardiac tumors. Okay, and about the cardiac infections and cardiac trauma we are going to discuss in the surgical part, but right now we are just focusing on these three broad classification of the cardiac serious disorders. Now most important is the end point or the finale. What happens is the final destination of all the disorder leads to heart failure. Okay, so in the final we're going to discuss about the heart failure and how we're going to manage a patient with the heart failure. Okay, the second part of the video I want to discuss is about how a particular pharyngitis, okay, inflammation of the pharynx because of maybe a viral or a bacterial cause, maybe a fungal, but basically the bacterial cause leads to rheumatic fever, which may be nearly equivalent to pneumonia. Okay, because obviously in the rheumatic fever there is cause of the valvular heart disease which cause the infective endocarditis. Okay, so there is a relation. Okay, how the pharyngitis causes the rheumatic fever, forget about the pneumonia right now, rheumatic fever, and ultimately which causes the valvular heart diseases. Okay, the valve diseases, right? And then it causes the infective endocarditis, now the respiratory disorders, basically I don't know what you have studied or what's there in the syllabus, basically are only basically cough and asthma. Cough is a symptom, so we'll discuss later. Okay, so in the respiratory disorder we are going to discuss about the airway disorders. Here there is asthma and bronchiectasis and COLD or COPD. Okay, we are going to discuss about them. Remember, asthma is reversible and COPD is irreversible. Okay, just to be clear, in the ILDs, interstitial lung diseases, there are multiple disorders, there are multiple group of disorders. Okay, so we'll discuss later. In the parenchymal and the pleural disease, there is pneumonia, there is empyema, there is ARDS. Okay, acute respiratory distress syndrome. Empyema, there is pus. Okay, In the miscellaneous, there is sleep apnea, obstructive sleep apnea syndrome. There is pulmonary thromboembolism. There is pulmonary artery hypertension. Okay, this is important. Now again, there are lung cancers. This may be squamous cell cancer, adenocancer, or oat cell cancer. So we are going to discuss all three later, but and ultimately leads to the respiratory failure. So this is the broad classification of the cardiorespiratory disorders. Okay, so we can again divide it into cardiac disorders and CVS disorders and the respiratory disorders. Okay, so these are the first points. Now when we are going to discuss our when we are going to discuss about the individual disorders, we are going to define the particular disease by the help of a keyword. Now how to extract a keyword, we are going to see for any disease what are the key points which we have to consider while seeing the clinical question. Okay, so the keyword is important. The second part is the epidemiology, that is the age of onset and gender. Okay, so many diseases are gender specific, many diseases are age specific. It may be happening in the newborn, it may be happening in the puberty age, it may be adult age or elderly population or pregnant population. We're going to see all these. Okay, so we are going to define it about the epidemiology, which is more common in a particular age of population. The next is the etiopathogenesis, causing the causes and the mechanism, that is the IT I said. Okay, the infection, inflammation, okay, iatrogenic, okay, idiopathic, T से ट्यूमर हो गया, ट्रॉमा, देन टॉक्सिन्स. ओके, सो इटियोपैथोजेनेसिस हो गया. क्लिनिकल फीचर्स, इट्स कॉमन और पैथोग्नोमिक इज समथिंग कॉल्ड very specific. Then there is a diagnosis, it may be used as a screening. We can screen the particular disease, we can be specific diagnosis, there is a gold standard, we do the investigation of choice. Okay, then there is treatment or management, defining the prognosis, whether it's good prognosis or a bad prognosis. Okay, so if there is a bad prognosis like in the cancer, we go for a palliative cure, or end of treatment cure. Okay, so now about the symptomology. See, symptomology is very vast, and in the cardiorespiratory disorders it's very specific. Okay, so here you have to understand it very it's very important. It's a VVIP topics in medicine. In symptomology, in cardiovascular, we are going to get angina as a symptom, then breathlessness as a symptom, and palpitation as a symptom. It's a very common and very important thing you should understand. In the respiratory, again there is breathlessness, okay, and there is cough. So there is cough, there is breathlessness in the respiratory disorders, and there is angina, breathlessness and palpitation in the CVS disorders. Okay, so breathlessness, other term is dyspnea, okay, or difficulty in breathing, short of breath. Okay, short of breath we can say dyspnea. There is cough के साथ there may be something called hemoptysis, blood in cough. Okay, now very commonly there is other term called edema. There is something called edema, and obviously palpitations are there. Angina to hai. Okay, we'll going to discuss angina in details. Okay, so first you can see that there is a common between breathlessness in both CVS and respiratory. So how can we differentiate between breathlessness of cardiac origin and breathlessness due to respiratory origin? Okay, you got a patient of 65-year-old man of complaining of shortness of breath. If a patient is a chronic smoker, we go for COPD. We are going for the COPD. Okay, infective exacerbation of a particular respiratory COLD, when causes the shortness of breath. Okay, so in the history there is smoking, we go for respiratory causes. In a cardiac patient, we see if the patient is obese, having type 2 diabetes, is going to have more diseases like ischemic heart diseases. Okay, so there may be cause of acute heart failure, and because of the acute heart failure, what happens? Suppose these are the lungs, and this is your heart. Okay, suppose this is your heart. Okay, This is your heart. So what happens now from your lungs? If there is a acute heart failure, if the heart is not working, not pumping, so what will happen? It will send back the blood to the lungs. When it send back the blood to the lungs, there is accumulation of fluid. There is accumulation of fluid in the lungs. There is accumulation of fluid in the lungs. Okay, so there is acute accumulation of fluid in the lungs, which causing the crepes, okay. So there is the acute acute heart failure, there is breathlessness present. Acute heart failure, there is breathlessness present. Okay, now what has happens in the for suppose, how can you differentiate? We are differentiating, right? So in response to the exhaustion caused by a patient, there is classical relation of a cardiac cause, but there is episodic or very poor correlation with the respiratory cause. So classic relation is because of the cardiac. So C से classical, C से cardiac. Okay, और respiratory में देखो, रेस्पिरेटरी में क्या है, देर इज ई प्रेजेंट एपिसोडिक. ओके, सो एपिसोडिक रिलेशंस. ठीक है, नाउ इम्पॉर्टेंट क्या है, सिम्टम्स अगेन एंजाइना, पैल्पिटेशन एंड इडीमा. और यहाँ पे क्या रहेगा, देर इज कफ, फीवर एंड हिमोप्टिसिस. ठीक है, तो एसोसिएटेड सिम्टम्स हम लोग डिफ्रेंशिएट कर सकते हैं. ओके, नाउ अगेन पल्स रेट, ब्लड प्रेशर, ठीक है, रेस्पिरेटरी रेट, वी कोरिलेट द जनरल एग्जामिनेशन फाइंडिंग्स with the severity, not with the cause. So even SpO2, so pulse rate, SpO2, respiratory rate, blood pressure are not specific for a cause, but we can grade the severity gradation of dyspnea can be done on the basis of general examination. Okay, now in the inspiratory crepitations there will be rales. So inspiratory crypts, I said the crypts will be present, it's called rales. So oscillatory findings में rales मिलेगा in case of cardiac, and there will be expiratory wheezing. So in asthma there is wheezing, so expiratory wheezing or rhonchi is present in the respiratory cause of breathlessness. So the very important assay is the BNP assay. Will take around 7 minutes to diagnose. It is costly, yes, it's costly, but every patient which is admitted are done with the BNP. Okay, so RT-BNP, what we do, RT-BNP assay we do, and it will be highly increased in case of acute heart failure, which is normal in the respiratory. So while doing BNP we can exclude the respiratory and cardiac. Okay, so BNP is the secreted by the ventricular cardiomyocyte in response to the stretch and strain on the ventricle, hence this is specific for the heart failure. Okay, so if BNP is more than 1000, we say that the patient have a poor prognosis, poor outcome may be present. Okay, now very important few more questions for your MCQ. This INI-CT you can be asked this kind of question. Okay, that soluble ST2 or galactine-3 these are the new markers for the heart failure. These are novel markers. They are not specifically present, the test is present in the labs. Okay, but we can diagnose the particular heart failure or breathlessness because of the heart failure. We can test the, as for BNP, there we can do soluble ST2 and galactine-3. They have equal sensitivity and have a better prognostic role. Okay, but no rapid test is available. Okay, now few key terms what I going to discuss are the circulation क्या होता है and perfusion क्या होता है. ठीक है, what is preload and what is afterload, what is Frank-Starling law. So this is what about the physiology. I was discussing about the important physiology which you have to remember, or we go back and remember. So we'll discuss when we are integrating the physiology with the medicine. Okay, so Frank-Starling law will discuss the stroke volume, concept of cardiac output, concept of cardiac index. So this is all about cardiac. And in the respiratory, we'll discuss about the ventilation perfusion ratios and about the diffusion. So ventilation, perfusion and diffusion is there in the respiratory. Okay, now the key investigations, what the important the investigations are there. So in the key investigation for the CVS, we have clinical examination, clinical examination, clinical examination. So you will get a long case, we'll get a long case on CVS. Okay, it is really very tough in your final medicine exam. Okay, because CVS we have to identify the murmurs or you have to examine. So see, cardiac CVS as well as the GIT, if you get a long case it's very tough. If you get a CNS case it's very easy. Okay, because CNS examination is easy, but CVS and GIT are very tough. I'm saying you, GIT I mean abdomen. Okay, all abdomen. Okay, so CVS examination, which are the points, it's a very short. I'm discussing about what are the important parameters which you have to understand while doing the clinical examination. First is the arterial pulse, second is the JVP waveforms, the pulses paradoxes, the Kussmaul sign, very important, the heart sounds and the murmurs. These all includes in the clinical examination. The second is the ECG. We are going to discuss in ECG in a very vast manner. Okay, so how a P wave will show the atrial depolarization, then QRS complex will do ventricular depolarization, then there is T wave, that is ventricular repolarization. Okay, now okay, so this is a wave, P wave, Q, R, S, T. Okay, now there is something important, these are segment, this is a PR segment, this is a PR segment, it is the baseline or a isoelectric line. This is how we defined what is the baseline. It is a baseline or electric line. Okay, now if we say about the PR interval, we actually include the wave also. So if we are saying PR interval, now this is PR interval and it includes the, yes, it includes the wave also, and it is the AV nodal conduction time, AV nodal conduction time. I think I'm correct. Let's see. Then there is something called ST segment. So there is ST segment. Okay, so here it is the term called J point. Here is the J point. Now there is something called Q or a capital Q. Okay, so small q is a physiological Q. Okay, this is the first negative deflection of ECG. Okay, small q, but a capital Q is something called, what we say, a pathological Q. A pathological Q will be more than 1 mm in amplitude, and it shows the size of an infarcted area. Okay, it's size of an infarcted area. It is actually nothing but the area of the dead myocardium, Okay, so we are going to discuss about these. Okay, I will also revise and I'll discuss about all the ECG. Okay, so also you know about echocardiogram, Okay, so and the color Doppler we use to see the echo. In short, we say the echo and then angiocoronary angiography to see the blockage. Okay, to see the blockage and all. Now for the respiratory, we do the chest X-ray. The chest X-ray is not we do for a PA view, posterior anterior view. Okay, HRCT, okay, high resolution CT image, and CT pulmonary angiography. So these are important radiological which we do in respiratory. Okay, in functional assessment methods, we do the pulmonary function test, where do we do the spirometry or DLCO readings. Okay, so we'll discuss about what is DLCO and spirometry. We'll do the arterial blood gas analysis. This is the first thing which we do from the artery blood. It is very important. In every ICU, morning and evening, we do the ABG. So this is the ABG gas analysis. ABG analysis. Okay. So apart from studying in the 20 minutes I've taken, there are specific disorders which we have to understand, and in very short, in I think 5 to 10 minutes, I'm going to discuss and summarize very important MCQs, okay, which may come. So in a pericardial disorder, there is a cardiac tamponade and constrictive pericarditis. In a sinus bradycardia and sinus tachycardia, we are going to discuss when we are discussing arrhythmia. Very important question is in a Brugada syndrome. There is a Brugada syndrome where oral amiodarone is used. So we have to discuss about the drugs. So let's discuss about some drugs, important drugs and important MCQs, right? So oral amiodarone, the amiodarone में iodine होता है. There is iodine, okay. So oral amiodarone is a drug of choice for Brugada syndrome. Now, drugs causing bradycardia and drugs causing tachycardia. So what are the drugs causing bradycardia? Is the beta blocker ivabradine. These two you know. The important drugs are amiodarone again and digoxin. Very important. Digoxin causes the bradycardia. Okay. Now for the tachycardia, there is sympathomimetics. So I think you remember in the ANS there are sympathomimetics. So we have discussed about many things in the ANS. So adrenaline is one of the important drugs, right? The salbutamol, again, where is the salbutamol? It is a beta agonist and it is used in the asthma, and theophylline is present in your tea. Whatever tea you are having, yes, theophylline is present, okay. Even in your chocolate also some amount of theophylline is present, okay. So with theobromine and caffeine. Now the sympathomimetics is very important. What is sympathomimetics? So all the drugs, the pressure agents, noradrenaline, ephedrine, dopamine, phenylephrine, okay. Then bronchodilators like terbutaline, salmeterol, salbutamol, formoterol, valmeterol. The CNS stimulants like amphetamines, okay, methylamphetamines, methamphetamines. The cardiac stimulants like adrenaline, dopamine, asuprenaline. The nasal decongestants like xylometazoline, oxymetazoline, napmethazoline, okay, pseudoephedrine, okay. The uterine stimulants like ritodrine, isoserpine, terbutaline, salbutamol. These all are uterine stimulants, relaxant, okay. Now anorectics are what? It decreases the appetite and causes weight loss like amphetamine, okay, fenfluramine, dexmedetomidine, or sibutramine, okay. So this is a very important classification. You have to keep tip of the tongue, and all these drugs discussed causing the sinus tachycardia. All these drugs causes the tachycardia. So when you take tea, it causes tachycardia, remember. Now arrhythmia, again, arrhythmia is something rhythm. There is a difference in the rhythm. So there is a dysfunctional rhythm, okay. So based on the heart rate, if there is less than 60 beats per minute, it causes the bradyarrhythmia. It is sinus bradycardia, as we have discussed, and there is heart block and AV block, and there is bundle branch block. So in the sinus tachycardia we have discussed, in the heart block or the atrioventricular valve block. So there is AV block, first degree block, second degree block, and third degree block. Third degree block is also known as complete heart block or AV dissociation. So there is a difference in the beating of atria will beat on its own, ventricle will beat on its own, okay. There is a AV dissociation or complete heart block. So most important thing which you have to remember here right now is palpitation is present only in second degree heart block. Palpitation is present only second degree heart block. First and third there is no palpitation, okay. The cause, very important. There are many causes, we will discuss later, but very important, drug induced amiodarone causes first degree heart block. Amiodarone causes first degree heart block. Acute rheumatic fever causes first degree heart block. Electrolyte imbalance causes first degree heart block. The ISD causes the second degree heart block. The degenerative changes and congenital SLE we'll discuss later. So this causes the third degree heart block. Okay. Now, very important, role of IV atropine, or the atropine trial. In the atropine trial, what we do, we give IV atropine in the heart block patients. If there is increase in heart rate, and more palpitation, it is the second degree heart block. If there is no increase in the heart rate, it is the third degree heart block. So by doing the atropine trial, we differentiate between the second degree and third degree heart block. Okay. So the second degree heart block, the palpitation is present, there is a missed beat, we'll discuss later. The PR interval, if there is varying, it is known as Mobitz 1, and if it is constant, it's known as Mobitz 2. Okay. Now the tachyarrhythmias. Okay. So here we have discussed about, there is a bradyarrhythmia, there is normal heart rate. So there is sinus arrhythmias we see in anxiety patient and young patients in 20 to 30 years. So in your age we see the sinus arrhythmia. Okay, the heart rate is normal, but you feel like your heart is pumping. Okay, so in anxiety patients, in young patients of your age, sinus arrhythmia is very, very common. Okay, the third is the tachyarrhythmias when beats is more than 100. So let's discuss about tachyarrhythmias. In the tachyarrhythmias, there are, in the classification, it's a very broad classification, but you have to understand, in the narrow QRS and broad QRS, we can differentiate between ventricular origin and supraventricular origin. Ventricular origin and supraventricular origin. In the supraventricular origin, the most common are the PSVT and the atrial fibrillation. In the atrial fibrillation, there will be no P wave. Very, very important question. In the atrial fibrillation, there will be no P wave. In the PSVT, the treatment is IV adenosine. Okay, adenosine drug is given. Okay. In the ventricular origin, there is ventricular tachycardia, VFib, or the ventricular fibrillation, torsade de pointes. Okay. So there are three problems, right? Ventricular tachycardia, where the drug of choice is amiodarone. Ventricular fibrillation, death का सबसे important cause. Torsade de pointes. Now, torsade de pointes can be treated with the magnesium sulfate. It's a very, very important question. We stop the 1A and 3 agents of the antiarrhythmic drugs. We'll discuss later. And we correct the potassium. This is a treatment for torsade de pointes. Is an excellent Viva and MCQ question. Okay, now torsade de pointes or polymorphic ventricular tachycardia, it's like a tribal dance with pointed spheres. Most commonly in more than 50 years and more in male more than female. Okay, caused by 1A drugs and class 3 agents. Class 3 agents are the potassium blockers. So when we discuss about SOBE-POCA, okay, and miscellaneous, so here in classification, it's the sodium blocker, second is the beta blockers, the third is the potassium channel blockers, and fourth is the calcium channel blockers. Here the important thing is, one is also divided into three: 1A, 1B, 1C. So in 1A there is quinidine and procainamide. In class 3, which is the potassium channel blocker, there is amiodarone, ibutolide, and sotalol. Now again, sotalol is a beta blocker with potassium channel blocking property. It is very important MCQ, sotalol. Okay. Now all these 5 agents, which are antiarrhythmic drugs, predisposes to after depolarization. Again, we go through the physiology. What is mean by after depolarization? Which increases the risk of torsade de pointes. So torsade de pointes, this is a very, very important classical question, right? Now it's very important, what are the drugs which causes increase in the QT interval? It's present in your KDT. In KDT book, its classical table is given. So I have just upgraded the table. So in the antiarrhythmic, there is quinidine, procainamide, diisopyramide, and propanophenone, amiodarone. Okay, diisopyramide also causes coronary steal syndrome. phenomenon or syndrome. Okay, so antimalarials like quinine, mefloquine, artemisinin, halofantin all increases the QT. There is a QT prolongation. So we'll be very specific, very when you give these agents, we have to see the ECG also. Okay, in the active bacterials is a classical AIMS question that sparfloxacin and moxifloxacin also increases the QT. Okay, and anti-TB drugs like bedaquinyl, which is used in the MDR TB, and other also drugs increases the QT. Okay, a prokinetic drug like cisapride, estimizole is the antihistaminics, and terfenadine is an antihistaminics. These are the CAT drugs which are banned, and these also increase the QT. Also, ibastine is an antihistaminic drug which causes the prolonged QT. Antidepressants, we have seen about the amitriptylines, very commonly tryptoma, which is given in majority of the patients, for antidepressant also and for pain also. Okay, used in neuropathic pain also. In all the tricyclic antidepressants can cause this prolong in the QT interval. Very important. Antipsychotics, again antipsychotic thioridazine, pimozide, aripiprazole, ziprasidone, all these 4 drugs can cause increase in QT, so be given very cautiously. Okay, now few one-liners. Okay, in MV replacement, in mitral valve replacement, there is a role of left atrial thrombus which causes the increased risk in embolization. So there is a 3 week of oral anticoagulation given. Okay, so in the valvular heart disease, okay, what we see, what are the drugs important? So 3 weeks of oral anticoagulation given after the mitral valve replacement. Okay, so again in mild to moderate aortic stenosis, okay, so medical closure can be done by the beta blockers, ACE inhibitors, and statins. If they fail, then we go for the AV replacement, and when we do the AV replacement, we give the oral anticoagulation. Okay, in chronic or acute MR, the medical treatment includes the beta blocker, ACE inhibitor, and the diuretics. Okay, now in infective endocarditis, as we discussed, there is a role of IV antibiotics. So here we give the first line IV penicillin or IV third generation cephalosporin like ceftriaxone. Okay, ceftriaxone. Okay, in MRSA, the drug of choice is vancomycin plus gentamicin. Okay, in prosthetic valve endocarditis, very very important question, AIMS question, IV nafcillin, IV gentamicin plus oral rifampicin. Role of rifampicin, again the 3 drugs are given in prosthetic valve endocarditis. Now MRSA in a critical state associated with renal failure, the 2 classical drugs given are the daptomycin and IV linezolid. IV linezolid and daptomycin are the reserved drug which is given in the last resort, where everything is MRSA, even vancomycin also, even in VRSA we can give, right? Now in restrictive cardiomyopathy, there is a trial of steroids, and this was asked in one of the important exams. In arrhythmogenic RV dysplasia, there is a role of oral amiodarone. So there is a role of oral amiodarone. So these are one-liners. It's a classical thing. So we have discussed about 34 minutes, and we have discussed a lot. Okay, so let's see. It's very interesting. We'll see you in other video.